Hello and welcome to part 3 of lower extremity anatomy. We're going to begin part 3 by talking about the arches of the foot. So there are two arches that we need to be familiar with, the longitudinal arch and the transverse arch. And arches are important because they provide a strong shock-absorbing support for the weight of the body. The longitudinal arch, notice, comprises a medial and a lateral component. Most of the arch is located on the medial and mid aspects of the foot. The longitudinal arch is important to us because the metatarsals sit at an angle to the image receptor because of this longitudinal arch. And so because of the arch and because the metatarsals sit at an angle, we have to angle our tube to compensate. The central ray should be angled towards the ankle at an angle matching the metatarsals. So in other words, the central ray should be perpendicular to the metatarsals. Okay, you always want the central ray coming like this. Remember, that's going to help prevent foreshortening or elongation, but we'll also be able to see through the joint spaces better. The transverse arch is located primarily along the plantar surface of the distal tarsals and the TMT joints. The transverse arch is primarily made up of the wedge-shaped cuneiforms, which you can see here, especially the smaller second and third cuneiforms in combination with the cuboid. Okay, so again, we're really worried about the longitudinal arch and how it impacts our tube angle. Okay, so let's review some anatomy now that we've discussed all of the tarsals. Let's review some anatomy. So A is pointing to the large tibia. B, calcaneus. C is the tuberosity of the calcaneus. D is the cuboid. E is the fifth metatarsal tuberosity. Here's the body of the fifth metatarsal here. F is the region of the superimposed cuneiforms. G is the navicular. H is that subtalar joint. So the joint below the talus, where the talus meets the calcaneus, and then I, of course, is the talus. And hopefully you were able to see that this is a lateral foot x-ray. And again, we'll practice labeling these anatomical structures in lab. So here is an x-ray of an oblique foot. So we've obliqued the foot medially 30 degrees. And here is that large sinus tarsi that I referred to in a previous presentation. Remember, through the sinus tarsi, ligaments pass. So there's a lot of anatomy here. I'm going to let you identify these anatomical structures on your own. So if you want to pause, you can certainly label this x-ray, A through O it looks like. But I've also provided the answers for you in the notes section of this PowerPoint. Okay, classifications of the lower limb joints. So we won't spend too much time on this. What I need you to know is that all lower extremity joints are classified as synovial. Remember, that is their structural classification, except the distal tib-fib joint. So where the tibia and fibula meet distally, that is not a synovial joint, that is a fibrous joint. All joints of the lower limb, except that distal tib-fib joint, are considered diarthroidal. And remember, that's their functional classification, and that means freely movable. The distal tib-fib joint is amphiarthroidal, which only allows slight movement. Okay? So everything we're talking about in the lower limb is synovial and diarthroidal with this one exception. Next, the surfaces of the foot. So let's review this. We talked about this earlier in the semester, but the surfaces of the foot are sometimes confusing because the top or anterior surface of the foot, remember, is called the dorsum. And dorsum or dorsal usually refers to the posterior aspect of the body, so that gets a little bit confusing. But dorsum in this case comes from the term dorsum pedis, which refers to the upper surface or the surface opposite of the sole of the foot. The sole of the foot is considered the posterior surface or plantar surface. Remember, I remember plantar surface because that's where you get plantar warts. These terms are important because they help us describe common projections of the foot. So for example, an AP foot is the same as saying a dorsal plantar projection. Okay, so that's what's depicted right here. Okay, and that's going to be the projection that we will learn in lab. Remember though, our central ray is going to be angled to match the longitudinal arch so that our metatarsals are perpendicular to our central ray. This is just illustrating that the central ray is coming from the anterior surface passing through to the posterior surface. Okay, last slide. Let's discuss real quickly any motions of the foot and ankle, because these are potentially confusing terms as well. Dorsiflexion, plantar flexion, inversion, and eversion. So the decrease of an angle or flexion between the dorsum pedis and the anterior part of the lower leg is called dorsiflexion. So in other words, you are decreasing the angle between the dorsum and the lower leg. You are flexing that ankle joint. I like to tell my patients, point your toes up towards the ceiling or point your toes back towards your body, however you'd like to say it. The opposite of dorsiflexion is plantar flexion. That is when you extend the ankle joint or point the toes downward. Okay, so plantar flexion and dorsiflexion, I need you to know these, and they are opposites. Inversion or varus is an inward turning or bending of the ankle and subtalar joints. Eversion is an outward turning or bending. So inversion would be medial, eversion would be lateral. But notice here, the lower leg does not rotate at all during inversion and eversion. And a lot of times physicians will do this position and hold the patient in this position to look for stress on these joints. Most sprained ankles result from an accidental forced inversion or eversion. So it's certainly not a natural position. We would never put stress on a joint and take the x-ray. That is something that a physician would come in and do. All right, that concludes the lower extremity anatomy. Remember, we'll discuss ankle joint and tib-fib in another presentation. And if you have any questions at all, please don't hesitate to reach out. Thank you.